I'll now hand over to you, Siobhan, and thank you very much.
Great. Thank you so much, Mary, and thank you for the invitation to speak today. It's really helpful to get an opportunity to share the results of our research with everybody. So today I'm going to talk a little bit about the development of an Irish model. So it's a number of years, and it's something that is very, very close to the end. So we have a very new model, but I'm just into it and kind of the research that led into it a little bit, and then towards the end of the talk I'll introduce you to the current version of the model. So first I just want to comment a little bit on, what is the case for dementia palliative care? So we know that dementia is a life-limiting illness, and the median survival is just 4.5 years. Now that changes depending on the dementia. People with Alzheimer's dementia might live longer than that on average, and people with more rare forms perhaps less than average. We know that it's a leading cause of death worldwide, as per the World Health Organization data. And there are currently no curative treatments for dementia, so all treatment is essentially palliative. A palliative care approach can be appropriate at any stage of dementia, and in some cases, the involvement of specialist palliative care can be appropriate depending on the individual's symptoms and their other care needs. And I suppose in dementia in particular, advanced care planning needs to be considered early. And I think a really important kind of point around dementia palliative care is that effective end-of-life care is made possible by a palliative approach to care being taken throughout the disease. Okay, then are people with dementia getting palliative care? So we know from numerous studies that people with dementia are less likely to be referred to specialist palliative care than cancer patients, despite being reported to have similar end-of-life symptom burden. So, there's lots of different reasons for this. I suppose dementia is different to other illnesses in lots of different ways, and people with dementia's palliative care needs in particular might be complicated by the prognosis first. So dementia typically has quite a slow disease progression. There's occasional periods of remission, and also people have frequent comorbidities. So it can be very difficult to prognosticate in dementia. People with dementia then experience some symptoms that might make palliative care particularly challenging. So things like their cognitive impairment and their communication difficulties. And also, as well as all their physical symptoms, the non-cognitive symptoms of dementia as well. Things like responsive behaviors, as they used to be called, can make care a little bit challenging. Something else that's quite particular to dementia is, problems around shared decision making. So particularly in advanced dementia, if we don't have the patient voice and they can't make decisions for themselves, that's an added complication. Carer stress is particularly significant. Of dementia, carers deal with a lot, before the person ever comes to end of. And we know that there's significant emotional implications for family members of people with dementia. Unfortunately, there's kind of a double stigma almost around dementia palliative care, because not amongst everyone, but amongst many people, there's still some misunderstandings of what palliative care is. Maybe that it's just for people with cancer, it just applies to what happens within a hospice. And then on top of that, dementia, much better in recent years as rates of diagnosis for dementia have increased. But there's still a certain element of stigma attached to the disease. And, that's reported to be within members of the general public, even people who have been affected by dementia themselves. different, some shame or stigma. And even within health and social care professionals, there may still be a little element of stigma, and maybe that sometimes comes from misunderstanding around the illness. So, why is this important, and why is it important right now? So data from England and Wales have shown that the overall demand for palliative care is expected to increase by up to 42.4% in the next 20 years. And that data actually identified that dementia is the primary driver of that increase. So I suppose, considering that resources are already stretched and we're expecting an increase in demand, it's really, really important to look at how can people with dementia be, best cared for within the system. And if people with dementia need a referral to specialist palliative care, what is an appropriate referral, and what palliative care needs can be met by the dementia team, so that there's not inappropriate and kind of overly burdensome referrals being made. So that kind of sets the context a little bit. Now, I probably don't need to spend long on the slide for this particular audience, but it's just always important to kind of differentiate. When we talk about palliative care for people with dementia, we're not talking about end-of-life care in terms of this model. We're talking about the active holistic care of patients with advanced progressive illness, and care that's applicable earlier in the course of the illness in conjunction with other treatments. That, of course, includes end-of-life care, but it's not limited to that. In the model for dementia palliative care, we very much have kind of considered the 3 levels of palliative care. So again, most of you are probably familiar with these, but one is the palliative care approach that all health and social care professionals, including dementia professionals, should be adopting as part of their practice. And the next step up then is general palliative care. So people with some training in palliative care, but it's not their main speciality. And then, of course, the highest level is specialist palliative care. So people who engage full-time in palliative care, specialist palliative care activities. So again, I'm going to come to this later, but a lot of palliative care for people with dementia, a lot of their needs can be addressed by a palliative care approach and general palliative care. So just as the last kind of piece of background, before I come on to our own project, there is one seminal paper that's kind of published on dementia palliative care. So this is the AIIHPC white paper by Jenny van der Steen and her colleagues on optimal palliative care for older people with dementia. So they identified 11 domains of optimal palliative care for people with dementia based on a Delphi study. So the domains they identified were person-centered care, communication, and shared decision-making, optimal treatment of symptoms and providing comfort, psychosocial and spiritual support, continuity of care, setting care goals and advanced care planning, prognostication and timely recognition of dying, avoiding overly aggressive, burdensome, or futile treatment, family care and involvement, education of the healthcare team, societal and ethical issues, and the applicability of palliative care. And so principles, they came from, if you look at them, some of them are very much palliative care principles, some of them are very much dementia principles, but actually there's a huge overlap there. I think because person-centered care is such a core tenet of dementia care, and that really speaks to kind of the holistic approach of palliative, I think a lot of dementia professionals are practicing their approach by nature. Domains kind of show. So this is kind of the background, and then kind of coming on to where did the origin of the current come from. In 2014, the Joint Programme for Neurodegenerative Disease and priorities for palliative and end-of-life care in neurodegenerative disease, and one of the recognised was considered models for care across Europe. Soon after this, I was involved in a workshop with Professor Timmins in a small consortium. So we got some funding from the Irish Research Council to host an interdisciplinary workshop on palliative care in neurodegeneration. We had some key speakers from Ireland and the UK, and at the end of the day, we had a panel discussion to talk about, what were the gaps, what was discussed on the day, and what were still the gaps in research evidence around delivering palliative care for people with dementia. And again, one of the things that came up was evidence for what are the best models of dementia palliative care. We did hear from speakers who, anecdotally talked about dementia palliative care services they were involved in, but really there is published to guide kind of the development of a model. So we published a paper based on the proceedings from that workshop, if anybody is interested. The details are there. Okay, so kind of with that background, in 2017, I was part of a team that was successful in getting funding for the Health Research Board to undertake the Model for Dementia Palliative Care project. So the project aim was to develop a model mapping out what services, assessments, and treatments a person living with dementia might need, so that the healthcare system can better organise their care. Now, something that was kind of a big decision we had to make about the project early on was what setting this model was going to apply to. So we know that in Ireland and the UK, about 2/3 of people with dementia live in the community. And for most, this is also where they want to live and be cared for. So at the time as well, I suppose as part of, this was done as a research project, and we had to kind of choose one setting to focus on, and where the real lack of evidence and the lack of research was for those living, in their own homes. There is some more research going on, kind of a particular project in the UK around looking at this for people living in long-term care. And, that's something that I'll touch on again later, but this model, it was decided, was going to first focus on people living at home. Something else to mention is that the model was designed to complement the National Dementia Office's model for dementia care. So this is kind of going on concurrently to the current Dementia Palliative Care project. So some of you might be aware the National Dementia Office have now developed a model for dementia care for Ireland, and the implementation should begin this year. And basically it's going to introduce, lots more dementia services. So the idea, we were really conscious from the beginning that this model for dementia palliative care will be something to complement the overall dementia care model. We didn't want this to be a separate. So I just have some detail there in the project team. So the principal investigator is Professor Suzanne Timmins, and the co-investigators then were a great team from across UCC, Ulster University, and UCD. And we also had an expert advisory board of people with dementia, family members, people affected by, people with experience of palliative care, also the National Dementia Office, and just a range of expert health and social care professionals from across Ireland and the UK. Okay, so this is an overview of the activities that were part of the Model for Dementia Palliative Care project. So I'm going to bring you through each of these now briefly. So we first undertook a scoping review of previous literature, and we also conducted a survey of experts regarding key model components. We conducted site evaluations of exemplary services in Ireland and the UK, and we then undertook a consultation process with key stakeholders in a draft model, which was kind of continuously refined. And as I said, we're very close now to the final model version. And I guess all of this as well was supported by knowledge transfer and exchange activities. And the All Ireland Institute was particularly, involved in this, in the knowledge exchange activities for the project as well. Okay, so to bring us to the scoping review first, I suppose the very first step in doing the Model for Dementia Palliative Care project was just to see what evidence actually exists out there so far. So the research question was, what is the evidence for the effectiveness of non-pharmacological components of dementia palliative care provided individually or together? So we're interested in both models, if they existed, but also if there was any interventions or studies on particular components of dementia palliative care. And we also looked for evidence about the economic cost or cost effectiveness of dementia palliative care interventions. So the databases we searched include Medline, Embase, Synol, Scopus, and the Cochrane Library. And this study has already been published, and the information on it is on this slide there. So if you're interested in the detail, you can look that up. But just as a very brief overview of the results, there were 18 articles that were included that met the criteria. And just to kind of comment on what the evidence looked like overall. So we found that most studies were limited to people with advanced dementia or who were requiring end-of-life care. So there's definitely still, you know, a bias maybe in the literature that when people are publishing around dementia palliative care, they're talking about care for people with really advanced dementia and not that more holistic kind of approach of palliative care that includes that kind of earlier care. Most of the included studies were of low to moderate quality. I suppose this is an area where it's really difficult to conduct, you know, large randomized control trials. Then there was some evidence on care delivery models. So there's 3 types of dementia palliative care models that we identified in the literature. Some were dementia services that were providing enhanced care. So, you know, that got some kind of extra resources and upskilling around palliative care, but that the person stayed within their kind of primary dementia service. There's also examples of specialist services that kind of provided enhanced care. And there were 3 papers reporting on kind of truly integrated services between dementia and specialist palliative care. So really the common elements across all those different services, you know, appear to be effective. Again, they weren't large randomized control trials, so it's very hard to make, but there was really promising results from each of them. For success were that they provide equipment for the person with dementia to remain at home, especially towards the end of life, that they facilitated medical intervention at home, that they included goals of care or advanced care planning. And again, particularly for people at home towards the end of life, that care was available, or some kind of support or care was available out of hours and on weekends. And then unfortunately, there was no full economic evaluations assessing cost effectiveness that we uncovered. Okay, so the next thing we did then, you know, we had kind of expected that there wouldn't be a lot of high quality evidence published in the literature. So to supplement this, we also conducted a survey of experts. So the aim of the survey was to explore key stakeholders' views on what a good model of care for people with dementia in the community might look like. So we developed an electronic survey and distributed it to a purposive sample of expert clinicians, academics, policymakers, and these are people across the Republic of Ireland, Northern Ireland, England, Wales, and Scotland. So again, it was purposive sample. So it was people, you know, who were registered or part of mailing lists. We also used a bit of snowball sampling where we asked people to also identify colleagues with particular expertise in dementia palliative care. So in total, there was 112 completed responses received. These were very much from people with a kind of a deeper understanding of this subject. And again, the results of this survey have also been published. So if you're interested, you can look up that for the detail. The respondents' characteristics, you know, there is more females than males, which probably represents health and social care professionals in both dementia and palliative care. There was people mostly from England, and also good chunks from the Republic of Ireland and Northern Ireland, less from Scotland and Wales. The discipline most represented was nursing, then managers and policymakers and doctors. And we also had some good representation from other allied health professionals and social work. And then some people who identified mainly in an academic post as opposed to a clinical post. Okay, so what were the results then of the expert survey? So overall, the themes or the components of a model for dementia palliative care that came up most often or that it provide information, education, and training, that it provides support for the carer, that it provides good access to all, needed services, that it provides very comprehensive and continuous support, integration of services, advanced care planning, and end-of-life care. So again, we're already now beginning to see some similar themes come up around what the key components might be. In the survey as well, we asked people about kind of implementation of a model, and they identified different potential barriers, and these were kind of grouped under 3 different headings. So first, under service organisation, one challenge people anticipated is the duplication or fragmentation of services. So in some places, there might be the different multidisciplinary teams to support a really holistic model, but then they might be more fragmented in other places. A lack of resources, of course, came up an awful lot. That's unfortunately not a surprise. And then some people felt that maybe dementia palliative care might not be seen as a priority, and that this could be a barrier to implementation. People felt there were still many misconceptions about dementia, as well as misconceptions about palliative care. In terms of provision, people mentioned disease-specific barriers. So, for example, what if someone didn't have a diagnosis of dementia? Also, the difficulty in predicting end of life in dementia, and the difficulty in providing good end of life care. Palliative care where there isn't an advanced care plan in place. Okay, and then the next piece of work we did was around service evaluations. So again, because we knew that the published evidence was going to be somewhat limited, we felt it would be really, really interesting and helpful to also look at, services that already existed, if they were working well, and kind of what were the factors to their success. So the aim of this phase of the project was to evaluate and model existing services to inform the development of the model for Ireland. So the methods, as part of that previous survey, we also asked those experts to suggest any. So we then compiled a long list of, I think, about nearly 50 services across Ireland, England, Northern Ireland, Wales and Scotland. And from those, we kind of had a set of criteria to choose our exemplar services, and we eventually chose 5 and to evaluate in detail. So we kind of started with physical site visits, but then COVID came in and changed the plans a little bit. So online data collection and online meetings with the different services. But the kind of data collection methods that we used from each of those 5 sites were staff interviews and staff surveys for people who just weren't there on the days that we were there. We also surveyed users, so no people with dementia, but family members who currently or previously had a person with dementia using the Dementia Palliative Care service. And we also asked for any routinely collected data that the service had. So if they had collected data on, referrals, subtypes of dementia, anything like that, we collected that as well. So we then described each service in detail using a complex logic model, and we compared the key components across the services using the REAIM framework. So just to kind of go through these briefly. So of the 5 services we evaluated, one was kind of an intellectual disability service, which was a kind of a little offshoot of this project. So I'm not going to go into that now. But of the other 4, so we found some of the services focused more, some were very much for people with dementia in their last year of life. Some were very much focused on the earlier stages. All had referral criteria based primarily on needs, not an age or dementia subtype. So it's very much on the needs for referral into the services. All had a real ethos and a really, showed of individualized and person-centered care. And all, even the smaller services, very much linked in with other local services and supports. That was key to their success. And the key activities across the services were symptom management for the patient, carer support, advanced care planning and out-of-hours support, typically by phone, to families and other health and social care professionals. So just to kind of mention briefly the services that we went to. So 2 of them were specialist palliative care led, kind of based around, a hospice, and then the community services around that. These kind of were open to anyone with palliative care needs, and that included people with dementia. And they had kind of particular upskilling of staff in dementia in particular. So they were, interesting examples. The other 2 then were both dementia-led services. One was led by a psychiatry of old age team in England. This was an advanced dementia service, so it was for people in their last year of life, and it was about helping them to die at home and to stay at home in their last year. It did require that the person had an informal carer, but out of that, it was all around having a key worker and making sure that the people at home had the right equipment in place, that, say, public health nursing or district nurses there were well coordinated, and that, and again, that out-of-hours support, particularly towards end of life and around transitions, was really valuable. And the last one was kind of a primary care-led service, but, again, by a dementia team. And this was all around linking in. So this was actually a service for carers, as opposed to all the others were services for the person with dementia, but that also included the carers. And this service, it was all around that early advanced care planning, understanding palliative care needs, understanding the individual really early, and getting really personalized kind of care plans in place. And the same team then, and the same key worker, caring for the people right up through and following death. So they were the models we looked at. So again, we took out the what worked well about each of those, and they each looked really, really different, and they're made up of very different teams in terms of what professionals were involved, but they basically all kind of delivered the same kind of activities. So then we come to the development of the draft model. So it was developed based on the results of the stakeholder survey, the scoping review, and the site evaluations. So we undertook a multi-phase consultation process to refine the draft model. So we kind of had 4 main rounds of this. So we got feedback from healthcare professionals and academics, from people with dementia and family members. And we did this through multiple phases, including interviews, focus groups, surveys, and finally a consensus meeting in person. Okay, so this is what the model looks like. So this is kind of a logic model to kind of graphically give an overview of the detailed model. So I'm just going to kind of bring you through a few little key points in it, because it's kind of too long to go into in its full detail here. But the inputs of the model include staff resources, local integrated care planning, staff education and upskilling, care information and education, information systems and equipment. The intervention then is a community model of dementia palliative care that supports people with dementia to continue living at home for as long as possible where preferred, is responsive to needs and is individualized. So then I suppose the meat of the project is these components. So what, to be an effective dementia palliative care service, what are the key components that need to be included? We then have some kind of intermediate outcomes that would result from each of the components and longer term outcomes. And down in blue here at the bottom, we have the contextual and external factors that we kind of heard were important to consider in implementation of the model. But really now I'm going to focus on what were the 6 key components of the model, because I think they can help to describe it best. So the first component of the model is all around comprehensive care that covers all dementia needs from diagnosis onwards. So the key principles and how we've kind of set up the model for dementia palliative care, the actual model is, so we have the overview here, and then within each component, we first describe it by introducing the key principles of that component. And then we give some examples of how those key principles are kind of actioned in practice. So for comprehensive care, we have key principles, including A palliative care approach is applicable from diagnosis in dementia. That goals of care might include improving quality of life, maximising comfort. This might be placed at different times. And comprehensive care addresses all treatment and care in dementia, including for non-cognitive symptoms of dementia. And the 4 pillars of palliative care being and spiritual. And this isn't a comprehensive list. I've just kind of picked out a few key principles and a few points kind of around each. So again, just a few examples from what we have of how might this look in a service. So regular discussion and agreement about current or future goals of care with the person with dementia and the carer supporter. That there's a regular needs assessment conducted by a member of the MDT, considering physical, psychological, social, and spiritual needs. The use of the best available tools to assess individual symptoms, kind of acknowledging that sometimes there aren't, perfect tools available. And also the availability of a range of non-pharmacological and pharmacological treatments to address symptoms. So again, this depends kind of on what is available locally, but things like Reiki or massage for agitation have shown some promise. Component 2 then is person-centered practice and care that tailors the person's care to their interests, abilities, history, and personality. And so the key principles of this include that preferred place of care should be considered, and where preferred, there should be effort made that people with dementia be cared for in their own home or the carer's home in the community for as long as possible, including death where that's possible and preferred. Advanced care planning should start early, ideally while the person with dementia can be actively involved. Advanced care planning is a process and must be revisited regularly. Person-centered care means that the person with dementia and family's specific needs at any particular point in time should be addressed. It requires good two-way communication, and information needs from person with dementia and family should be elicited and addressed. And it includes co-design of the care plan and flexible delivery of care. Okay, so what might that then look like in a service? So firstly, the emphasis of the service should be to support the person in what they can still do, not in doing it for them. So what's really, really important is home support, so that this is provided as an intrinsic part of the service. And really importantly, that home support includes 1, care to support a person to continue to live a meaningful life. So that's home support for companionship, support with meaningful or enjoyable activities, as well as 2, care at home for practical care needs, the more physical needs. And the home support needs, for it to be effective, it has to be responsive and flexible, and it should be continued into end of life or augmented to include end of life care if required. Conversations around prognosis and advanced care planning should occur at the earliest appropriate opportunity, facilitated by a core member of the MDT in a suitable location. And this conversation is revisited and documented regularly as provided in the Advanced Decision-Making Capacity Act. Component 3 then is around integrated care that links people with services that work seamlessly together. And the key principles include dementia services that are trained in general palliative care approach and specialist palliative care working together. Care would usually be led by dementia services, but with support from specialist palliative care where required. So this could be a community liaison SPC nurse on the MDT, phone support, access to specialist support. Care can also be based in specialist palliative care with dementia specialist nurse access. So if someone, with dementia is under specialist palliative care, for different reasons, but that specialist palliative care still have access to that dementia specialist. So another principle is that there's excellent community team to support the person with dementia living at home until death, that every member of the healthcare team should have adequate skills to apply a palliative care approach to dementia, and that there is a key worker to coordinate all of this care, and that's really, really important. So what might this look like? Again, the MDT would usually be led by the dementia service, such as a memory assessment and support service, and I'll talk about what that is in a minute, with ongoing input from specialist palliative care community services. For people with dementia who are not under a memory service, their GP should be able to refer them directly to specialist palliative care services where a need has been identified. All people with dementia and families should have a single named point of contact to the core service providing their dementia palliative care. This person should have access across settings, including the person's home. Okay, component 4 then is accessible care that ensures a basic level of support to everyone, regardless of location, time, illness, or ability. And the key principles of accessible care include more and flexible home care hours to meet care needs and provide respite to carers. Equal access based on need to palliative care services, including specialist palliative care for people with dementia as for people with other life-limiting illnesses and regardless of their location. And dementia palliative care in the community needs to be available in a responsive and timely manner for it to be effective. So what might this look like? The overarching model of care for dementia specifies dementia services for community hubs. Home care hours need to be available to all people with dementia living in the community who need them. These hours must be flexible so that they can best meet the needs of the individual. And again, that might not always be a physical care need. The service provides urgent review, such as via a day hospital type service to address symptoms that might avoid a trip to acute hospital or A&E. And for people undergoing a period of acute illness at home, phone support from relevant consultant or advanced nurse practitioner should be available 24/7. Then component 5 is around care for the carer or supporter, and that ensures that the family members are enabled to support the person with dementia and that their own needs are met. So I suppose particularly for a model that is hoping to keep caring for people with dementia in their own homes, specific support for their family is just vital for that. So the key principles include the carer should be involved in decision making at all stages, including if a person with dementia is transferred to long-term care or hospice and during periods of hospitalization. Supports must be tailored to the specific needs of the carer, and both individualized and group supports should be available. There must be effective respite to benefit both the person with dementia and the carer, and carers must be assessed for and provided with support for anticipatory grief, prolonged grief, and bereavement care before and after death. So what might that look like in a service? The main family carer supporter is defined, even if not directly providing care anymore. Other family carers and supporters are defined also. The primary service inquires about the carer's own needs regularly. Effective, acceptable respite options in and out of the home should be easily accessible. Carers and supporters should receive comprehensive bereavement support from members of the MDT before and after death, and more specialised bereavement support is also available locally. And the final component then is end-of-life care, ensuring a dignified death with the person's preferred place with limited suffering. And key principles of end-of-life care include a comfortable environment of death in the person's own home where possible and preferred. Questions of the terminal nature of dementia might families' feelings of preparedness. Difficulties in prognosticating end of life should be acknowledged, but clinical judgment and tools should be used to guide treatment. And aggressive, burdensome, or futile treatments should be avoided at end of life. So what might that look like in a service? So first, that the honest conversations around end of life occur and in advance and are documented. The MDT provides information to families around dying with dignity and what symptoms to expect in the person who is dying with dementia. That a comfortable environment at death is provided. So for home death, that involves close working with the community MDT, such as the GP and public health nurses, to ensure necessary equipment, SPC input, such as palliative care nurses, to manage syringe drivers at home and enhance support. And night nursing services are really important. These definitely need to be further resourced, and these should be available for the final days of life for people with dementia. So that's a bit of a whistle-stop tour, I suppose. There's a lot more detail in the model itself. So I've just given a few examples from each of the 6 key components. But I guess, what I'd like to focus on for a second is that those key components, if implemented longer term, should result in more people with dementia being treated with respect, dignity, and compassion, improve well-being of people with dementia and their families, improve quality of care, including better clinical outcomes and lower morbidity, improve patient experiences, people with dementia being cared for and dying in their preferred place of care, improve death and bereavement experience, a more empowered and engaged staff, and a more efficient use of existing resources. Okay, so what's next now that we have, the near final model? So as I said at the start, we have designed it to be very complementary of the National Dementia Office's overall model. And on this slide here, I've listed the core principles of the model of care for dementia. And as you can see, they overlap a lot with our dementia palliative care kind of model components: person-centered approach, citizenship, integration, personal focused outcome, timeliness. So it's great. So a lot of the overall dementia care is going to kind of pick up on that palliative care approach. So the implementation phase for the overall dementia model will commence in the coming months, and these new dementia services will, should soon be staffed and opened. So the implementation then of the palliative care model will follow that overall implementation phase. So the idea is that, the new dementia model of care is going to be kind of focused on and implemented, and then we look at, what is covered in the overall model and what needs to kind of provide the level of dementia palliative care that we're describing. To work then, hope look at long-term care and other settings. So we've kind of put our focus, in one place for now, and we're to expand it out then in the future. And I'm just going to very briefly, for anyone here who's not kind of familiar with the model of care for dementia that's upcoming, very, very briefly, it's basically looking at the different levels where people with dementia can be diagnosed with dementia and cared for. So people with very, very low complexity might be mainly cared for within primary care, also people with low complexity. And then we've kind of two levels of secondary care. So generic care, so that's people with dementia, again, with low complexity, often with other comorbidities that are already under, say, an older person's clinic. It's expected that in the new model, most people with dementia will be diagnosed and cared within this specialised secondary care. So it includes both cognitive neurology clinics and memory assessment and support services. So these look after people with moderate, kind of within the memory assessment and support services, as well as diagnostic services. There's also post-diagnostic support pathways, which is really important and something that had been kind of lacking so far. There's also brain health, so about, what can we actually do to slow down dementia, to, what risk factors can we look at? So that's a really comprehensive service. It also speaks about continuity with other services, care planning, and that really holistic kind of post-diagnostic support. So looking at the person's physical and spiritual needs. So it's within here that we expect a lot of the person's dementia to be kind of addressed. There's also regional specialist memory clinics, but that's more for kind of diagnosing complex cases like young onset dementia. And those regional clinics would very much refer people back to their local memory assessment and support services. And so I hope that just gives a little idea of where we're going with the model of care for dementia and where this where this the actual model for dementia palliative care is going to fit in here. Just to comment as well on the role of specialist palliative care, this is something that we, had lots of discussions with different people on when developing the model. So again, as I said at the very start, with the increasing demand for palliative care, we have to be really careful of the appropriateness of referrals to those services. And where we kind of are at the model in the minute is it's using the palliative care needs assessment guidance to really look at just kind of the overall needs of someone with dementia. Can those needs be met within, the quite well-resourced dementia services, and so just palliative care might be appropriate. But really that's going to involve different disciplines working together to have a good understanding of everyone's roles. Yes, so that's kind of brings me to the end of the talk. So just in conclusion, I'd say the hope of this project is that every person living with dementia in Ireland will receive the best possible palliative care, including the appropriate level of palliative care. And I have my references on the slide for anyone interested, and I'd be happy to answer any questions.